Ladies and gentlemen, welcome to the Lake Superior Quality Innovation Network and Macomb County Community Mental Health Overview of Substance Abuse Disorders, Diagnostic Criteria, and Medications Used in Treatment. Your host for today, Mark Lausch, will now begin.
Good afternoon, everyone. This is Mark Lausch from MPRO, and I want to welcome all of you today to this webinar on behalf of MPRO and Macomb County Community Mental Health. And our webinar today is with Dr. Cory Waller. He's going to be talking about overview of substance use disorders, diagnostic criteria, and medications used in treatment. Just before we begin, just a couple housekeeping notes. The webinar today is being funded by Macomb County Community Mental Health under a Health Innovation Grant from the Michigan Department of Health and Human Services. I'd like to thank Susan Goff and Rosa Thomas from Macomb CMH for their support and assistance in making this presentation possible. So I want to thank Gavin Bates from MPRO for his expertise in coordinating and promoting this event. We will not be offering CEs for the webinar. However, you'd be able to get a certificate of participation at the end of the presentation once you complete the evaluation. I'd now like to introduce Dr. Cory Waller, who is the Director of Integrative Medicine at Spectrum Health in Grand Rapids, Michigan. Dr. Waller is an addiction, pain, and emergency medicine specialist in Grand Rapids. He works with the Spectrum Health System, a fully integrated health system with 11 hospitals and over 1,000 employed physicians. He is the medical director of the Spectrum Health Medical Group Center for Integrative Medicine, the medical chief of pain medicine to the Spectrum Health Hospital System, as well as substance use disorders medical director at Lakeshore Regional Partners. Dr. Waller's special interests include understanding the biopsychosocial and financial impact of high-cost complex patients, pregnant patients with a substance use disorder, and the complex interaction of pain and addiction. Please join me in welcoming Dr. Cory Waller MD.
All right. Webinar gets started. Excellent. All right, so we're going to run through a few things with this, and part of it is one, the concept of addiction, but then also, we're going to talk about some very specific things about addiction, meaning I want to get granular enough so that when you walk away, you can change something that you do today. And so it's always difficult, on a webinar without seeing the audience to know exactly how things are being received. So my goal will be to make sure that we hit all the objectives, and I'll make sure and leave plenty of time for questions. And if there are none, I will still use up the time to give more information. But I think it's important to get the understanding of why we're talking about this and how to reframe the context of how addiction is within your daily treatment pathways, as well as when you start to screen for patients or see patients, and maybe even the connection with your family members or friends that have had to deal with this. So as we go through, we're obviously going to look to understand the concept, but let's drill down on that a little more. So if we're going to start to think about addiction, we need to understand that you really need three major things to survive in life, and you need food, water, and dopamine. And dopamine is this chemical in the brain that's responsible for really the desire to obtain food and water and to obtain happiness and the way in which we interact with the world in a better way. So if somebody pats you on the back and says, "You've done a great job today, so you should really do better," and you do better because you're motivated. And that motivation, that little piece, that little voice inside your head, a little piece of the brain that helps you to get up a little earlier the next day and do a little more throughout the day, that's all driven by dopamine. And that dopamine is required for, the connection between our loved ones and friends and all of this. So really, without dopamine, then food and water don't even creep into the mind as something that you really need. So what is a normal level of dopamine? When we talk about dopamine, we have to look at a person who gets up and goes to work on a Monday and goes to work on Tuesday and Wednesday and Thursday and still motivates to get up and do those things and, holds all their family obligations. Well, this is a person whose dopamine level sits at around 50 nanograms per deciliter, so 50 nanograms per deciliter. What's nice about this is we actually know the amount. And we know where it is. It's in this part of the brain called the nucleus accumbens. And so the fact that we know how much and where really puts the knowledge about the neuroscience of addiction way ahead of the understanding of depression or anxiety or schizophrenia or schizoaffective disorder, all these other things that we hear about a lot. we really do know more about addiction. And when we look at this 50 nanograms per deciliter as being kind of your normal day, the worst day, the day that you call in and you fake vomit on the phone so you don't have to go to work and just decide you're not going to do anything, you don't even get out of your pajamas. A general worst day for us is 40 to 42 nanograms per deciliter, so not much worse. If we look at what is the best day of our lives, this 2% body fat, you win the lottery, you're hanging out on the beach somewhere and really soaking up the sun, that day is maximized right at around 100 nanograms per deciliter. So our normal physiological max is sitting up at this 100 nanograms per deciliter. And this allows us to be elated and super happy and motivated to do other stuff. But what it doesn't do is it doesn't impede our ability to assess for risk, to assess that what bad things could be happening if I don't pay attention. So because of that, this really does hit a maximum that we should be able to attain so that we don't do stupid things. And you can't always eliminate those. That could just be a personal choice. But at the same time, we really do evaluate what's going on around us before it happens. So if we look at your best food ever, we've looked at this, we take these studies were done on medical students where they basically would deprive them of the food, for a little while and look at the brain and see how that affects that part of the nucleus accumbens, and their favorite food would be about 94 nanograms per deciliter, consuming that while you're hungry. We did studies to determine how sex impacted that, and it actually only goes up to 92, so that's so bummer. But the reality is that 100 is our maximum, 50 is where we should be hanging out. So this is where the problem starts, is that when we begin to look at what substances do, we look at things like methamphetamine. So methamphetamine will raise that dopamine up to 1,100 nanograms per deciliter, so more than 10 times the amount of what it's supposed to be in the central, axis of the brain. And when that happens, we lose that capability to make risk-based changes or decisions while that's happening. And then, heroin is about 975. You have alcohol that's in the high 800s, and marijuana that fits in the high 600s. So there really is no substance that we would call addictive that doesn't significantly raise dopamine above the normal physiologic level. And that goes for glucose for some people as well. And supermorbid obesity is we're finding the same axis, the same place in the brain that gets stimulated with sugar no differently than it would with marijuana or alcohol. And therefore, the behaviors with supermorbid obesity look much the same as behaviors with patients with an opioid addiction. This happens for gambling addiction and sex addiction. We're finding it's all still fundamentally the final common pathway is this nucleus accumbens. But one thing the brain doesn't like to be, it doesn't like to be told what to do. So if it goes up to 1,100, the next time you use it, it's 1,000, and then over time it goes down to 900 and 500 and 300. This dopamine release each time you use, finally down to the point where when you use methamphetamine, it'll only go up to about 150 to 200. So it's still going to go above that 100, which is, that stimulated feeling that keeps driving the use. But when you remove that, the brain is, tried to compensate for that continued high use. And when you remove that, what you end up with is an average normal daily dopamine level of around 30 on your best day, and then about 15 on your average day, and below 10 on your bad day. So this is really important, because if the body is compensated and decreased the production of dopamine so it can get it back to normal, and we remove the drug, now what we see is without the drug stimulating that part of the brain, there's not enough chemical in there to actually make you get out of bed, to make you get up and get food or water, or to, quote, motivate. Because if you can't motivate, then you're not able to do any of the things that we really need or want patients to do for treatment. And it's not a decision at this point, because when the dopamine is that low, we actually lose the ability to allocate emotional memory. And without motivation or emotional memory, you can't be really happy or sad or motivated to go do anything. So it shouldn't be a frustration when these patients do it. It's just a symptom of the disease when they're not showing up for an appointment, or they're not leaving their house, or they're not even getting out of their pajamas. I mean, these are things that are very dopamine dependent. And until we regulate dopamine up to a higher level, then we're not going to be able to get that patient better. So one of the things that we've realized is that because we identified dopamine as one of the major issues in this, there are natural ways and there are non-natural ways to raise dopamine. So this is why we've ended up with two completely different pathways for treatment for substance use disorders. And one of those is, what's been happening for the last 70 years, which is an abstinence-based approach to this. So for patients who have what I call good social economy, meaning that they have a stable family, they have supportive friends, they have a job that they want to keep, they have these things that they really want to do, that by itself, having all of those surround you and help you, enables your dopamine level to go up back to that area where you can start to motivate to do the behavioral therapies required for change to then stabilize that disease. So when somebody says abstinence-based treatment is the best way to go, they're right for a certain group of people. And so I treat patients who are physicians, and so those physicians, I have very few of them on medication because they don't need it. They do well without it, and we use self-help modalities, and we use directed cognitive behavioral therapy, and what we call contingency management, where you have to call every night at 10 o'clock to determine if you have to pee in a cup the next morning, and that happens every day for 5 years for physicians who have been found to have addiction, and then if they fail in that pathway, then they can lose their license and their entire livelihood, and so that's a lot of motivation for these patients. And the difference is that for my patients, which I see mainly Medicaid, about 92% of my patients are Medicaid patients, those same things don't apply. And so for that group of patients, they don't have that inherent stable social capital, and they're not able to raise that dopamine level in a more, quote, natural way, because they don't have any of the things in place that would require that. And so we have to artificially learn to raise that dopamine, which is what brings us to medication-assisted treatment. And if we look at the part of the brain, that we're dealing with, you see the green on the screen, which is the nucleus accumbens, and the orange, which is the ventral tegmental area and the amygdala, and these other parts of the brain, anterior cingulate gyrus, and the nucleus, and we talked about that. But and as we start to look at this, those parts of the brain cause this behavior that we see. So this lack of dopamine, which creates craving, which puts the patient into survival mode, because without dopamine you can't do anything else, and then that causes that primal action. And as we talked about in that group, we want to raise dopamine, but if we can't do it through normal conversational means or self-help pathways because they don't have the stable, we have to look at other ways to do that. And the other ways that we do that is really to artificially raise dopamine. And we artificially raise dopamine using medication. And this medication, when it raises dopamine, starts to stabilize these behaviors that become very frustrating for us. And that's how we define addiction. So if we're stabilizing behavior, we're actually stabilizing the disease, because we define addiction based on 9 behaviors and 2 physiologic phenomena. So if their behavior is worsening, that should really be seen as a symptom of the disease and not a frustration. To fire a patient from an office or to not want to deal with them because they, quote, aren't ready or don't want to do better. That's really not the case. What it just means is that their disease is less treated and more severe at this point in time. And so because of that, we have to start moving forward with our thinking and how we can then stabilize dopamine to be able to onboard these other aspects. So if we look at how we are going to really by proxy define how low their dopamine is, by proxy we can do that based on behaviors. And if you look at the DSM-V, we've moved from this abuse dependence definition and moved this over to substance use disorder. And that's how we've done with the other ones. And I think this is a much better pathway for encapsulating what's going on. And you classify as mild, moderate, or severe. And those, again, if they meet for 2 to 3 criteria or 4 to 6 criteria or 7 to 11 criteria, those are patients who have mild, moderate, or severe disease, and those criteria are all behavioral criteria, the exception of the 2 physiologic ones. And so really what we're treating is behavior. And so that's what we should be looking at if we're going to treat these patients. So if we put a patient on buprenorphine or methadone or naltrexone, what we want to see is not necessarily a clean urine. That's a step. But that still doesn't define whether or not this person has significantly improved their overall behaviors. So we don't define addiction based on a positive or negative urine drug screen. We define it based on the behaviors associated with obtaining and using the drug. And if we look, closely at it, and we're going to dig into the actual diagnostic criteria real quick, this is defined as really this problematic pattern of opioid use leading to clinically significant impairment or distress is manifested by at least two of the following occurring within a 12-month period. And if you have two or more, then you meet for mild substance use disorder. Now remember, the two physiologic ones, which are tolerance and withdrawal if you remove the drug, those aren't usable if a patient is prescribed opioids for pain. So if a patient is prescribed opioids for pain, everybody has tolerance and would withdraw if we pull it back. So those have to be pulled off the list. Otherwise, everybody with pain who's prescribed would automatically meet for SUD. We know that's not true. But if we look at the impaired control of the substance, right? So this means it's taken in larger amounts or for a longer period of time. There's a persistent desire or this craving or unsuccessful efforts to cut down. A lot of time is spent in the activities necessary to obtain the substance and or to use it or to recover from it. So basically, your life is defined by having this disease, with that one. And then this craving or strong desire or urge to use the substance. Now this is the first time that craving has actually been a part of the diagnostic criteria. And so let me describe craving a little bit and what that means from a neurobiological sense, because this is no longer an abstract concept. If we look at craving in the brain and we look at that picture of the brain, what that shows is that craving lives in this area of the brain called the anterior cingulate gyrus and the lateral bed nuclei of the amygdala. I tell you this not because you're going to get a quiz on this at the end, but you should know that we know where it is. We know what part of the brain is activated for craving. So if we look at those two areas and we try to figure out how, quote, strong is craving for a drug in a patient who has an addiction, we have to figure out what we compare it to. So what we started to compare it to are things like starvation or dehydration and what that looks like on a functional MRI. So there was an experiment done where patients didn't get anything to drink for 72 hours. And then they were functionally MRI'd while they were talking about waterfalls and swimming pools, and they were like sprinkling water on their legs and, wetting their lips and stuff like that, and then they would look at their brain. And in the relative size, the amount of craving signal that came from the brain is about the size of a baseball, and that's a relative size. And then we looked at food, where they didn't eat for 5 days, and then we would talk about their favorite food, and we would put it in the MRI room, and they could smell it and know about it and talk about it. And the craving for that food after 5 days of not eating is about the relative size of a basketball. And so as we start to look at that, then we looked at patients who had been clean for 30 days or 1 year. And then we had them get in the functional MRI, talk about the first time they used their drug, the last time they used their drug, and the best memory they had about using the drug. So the relative size, and it was no different for 30 days or a year, which is really helps us to understand the length of time needed to treat this disease, is the size of a baseball field in a relative size as compared to starving or dying of dehydration. So this is significant, and that overwhelms all other aspects of risk assessment. So craving becomes so important in this. So craving, if it is a primal urge to obtain dopamine, it doesn't matter what the drug is. And for different patients who have different brain makeups, that's why their drug of choice may be alcohol, or it may be heroin, or it may be benzodiazepine. That's why there are different drugs of choice, because different brains react differently. But the final common pathway is this dopamine. And that craving is not for the specific drug, really. That's the secondary means by which they raise the dopamine, which is what the body is really craving. So that's why craving has become so important in understanding where we are with the treatment of these patients. If we go to the social impairment aspect of this, we look at the recurrent substance use that results in failure to fulfill major roles or obligations, and that's at work, school, or home. Did you lose your job? Are you just sitting in a room not doing anything, your familial duties, with your kids? Do you I mean, believe me, after a long week, there are times I go home and my 3 and 5-year-old basically get a totally anhedonia blank stare from me. That's the reality of what we do. But at the same time, this is you basically don't leave the room. You sleep all day. You only leave to go obtain the drug, or you keep it where it is and you just take it and you don't do any of that. Or you've lost your job, or you get dropped out of school. Or continue the substance use despite having, persistent or recurrent social interpersonal problems. Those may seem equivalent, but they're really different. And this one is more described like, have you had a significant increase in your, quote, bad mood? Do you now go off on somebody after 2 seconds of an interaction? Do you escalate rapidly to anger and start yelling at everyone? Those are things that we start looking at for that impairment. And then it ultimately comes down to important social, occupational, or recreational activities are just given up, or reduced. So this is, you no longer really hang out with your non-using friends. You don't hang out with your family. You don't do any of the normal social building things that help to stabilize dopamine. And then the only thing that you have stabilizing dopamine at this point is the drug. And this is a real problem, because then it becomes the social isolation and all those bridges that get burned over time. And then if we look at the pharmacological things, that's when we start to look at tolerance and withdrawal. Like I say, these are things that we would expect in a normal, interaction for a patient to have no matter what. I mean, if they're on an opioid, if they're prescribed an opioid for pain, they're going to do it. So in my clinic, I see patients with chronic pain, and very few patients that show up in the emergency department who have a substance use disorder say, hey, I have a substance use disorder. Please don't give me narcotics. They say, I have back pain. Please do give me narcotics. So a lot of them show up with pain, and we have to tease out whether or not they have pain versus a substance use disorder. It's usually pretty easy to do that, and it takes less than 3 days to have a definitive answer. Because when they show up the first time, we do a risk assessment, suicide risk assessment, as well as just a diversion risk assessment, all that. But we ask them very specifically, what's worked for your pain in the past? And routinely they'll say, well, Oxy's always worked, or this has worked. And I say, well, what dose? And they'll give me a dose. And I write that for 3 days. If it's safe, obviously. I mean, if they're like, I take 100 Oxy a day and it's super awesome, I don't write that. But within reason and after a good safety assessment. So the thing about this disease is you have significant impaired control with utilization. And so ubiquitously, those patients, you write for 3 days of meds and a follow-up back in the office, they're calling you on day 1 or day 2, and they're either out of meds, they've lost their meds, somebody stole their meds, anything you can imagine. That enables me to then have the immediate conversation of, or they're not working. They'll even say, well, it didn't work. I'm like, well, that's exactly what you told me. And then that enables us to have that next conversation of, look, it doesn't really matter that this stuff has happened, because we now know something that we used to not know, that these drugs actually do harm rather than good. I have a few hundred publications that show harm from these medications. I don't have any that show positive improvements in function after 1 year. None. Not one. And so the overwhelming evidence is that opioids for pain is a dead end. And so you can have that conversation as you're trying to tease out each of these criteria that you're trying to get them listed on. So if they come in with pain and you know it's an SUD, if you tell them it's a substance use disorder immediately, because it takes me about 30 seconds to diagnose this nowadays after doing this for years, they need to come along with you. This is a process. It's not, hey, you have a substance use disorder. I'm not writing you for opioids, so please come back in 3 days and we'll see you again. Or I'll see you in a month. Because our retention and treatment for that's about 0. And so you have to work through this. Sometimes they get referred to you for a substance use disorder, or they just come out and say, I want help. And that's great. Those are the easy ones. It's the ones that really live inside of this pain cocoon and then use that as the proxy for every bad behavior that they have. And that really is something that that conversation can be very difficult to have. So let's talk about some of the modifiers, and these are new, and I actually like these a lot. And so you can specify on this diagnostic criteria if it's in early remission or in sustained remission. So this is great. So if I have a patient that I put on buprenorphine and they stop utilizing other opioids, and that's been sustained for a period of time, I can say that they're in early remission on opioid replacement therapy, which is great because that helps me to understand that the medication is working. So what about somebody who's still smoking weed or using cocaine, and I'm treating them for an opioid use disorder? So they come in with polysubstance, and I put them on buprenorphine or Suboxone or Zubzol or the bupropion one. If I put them on that, and they stop utilizing opioids except for the one that I'm prescribing, but they're still using cocaine or marijuana. Frustrating, right? Very frustrating. Doesn't change the fact that the medication has still significantly improved the utilization of opioids. So the way that those people would be diagnosed is that it's opioid use disorder in early remission on opioid replacement therapy with an active moderate marijuana use disorder and a severe cocaine use disorder, if they meet those other criteria that we talked about. So each of these need to be looked at separately, and if you think that you're going to put somebody on Suboxone and immediately see them decrease their marijuana, you might actually be smoking marijuana yourself, because that's just not going to happen. I have not had that happen where a patient's like, I should probably also stop smoking weed on day one when I start them on buprenorphine. So we have to take this step by step. You get them in a stable place, you stabilize their dopamine axis, and then you just start to peel back each of these pathways. And if you continue to do that in an integrated fashion, which means that you cannot write these meds without significant onboarding of behavioral therapies, then, but if you do that in an integrated fashion in about 18 months to 2 years, which is about the time it takes that dopamine axis to stabilize, you're going to be able to, start to then say in remission for all of those. So this is something that becomes important, is knowing that persistent, ongoing interaction is the only thing, and retention and treatment is the only thing that's been shown to improve outcomes. So you have to sometimes bend early so that they come back and then modify that over time. Now that doesn't mean that you write them for a bunch of benzos and all this stuff. You have to have absolute solid walls around certain things, but you be pliable with this. We're pliable for other diseases, and this is one of those that we should also be pliable with. All right, let's talk about the treatments. So we talked about the dopamine issue and how we need to augment that in some patients. When we augment dopamine, we can do that safely with appropriately dosed buprenorphine and methadone. I say appropriately dosed because every patient shouldn't be put on the maximum dose of buprenorphine. Not every patient needs to be on 150 milligrams of methadone. In fact, very few do. And so when we look at those two that raise dopamine, those are different meds than like naltrexone, which is an exceptionally good medication. But for early use in a patient in an open environment, it's difficult for retention and treatment. And so we moved to get most of our patients toward naltrexone, and we transition a lot of them off of methadone or buprenorphine onto naltrexone. And for those who have already been clean or detox, we can put them on naltrexone as well if they have other positive factors and they're motivated. But if we look at the buprenorphine and methadone, those should be dosed to effect. So if you start them on these medications, what we should see when we start the medication is a stabilization of behavior. Not a full improvement, because that requires behavior modification. So we can see stabilization of the behavior and emotional context of the behaviors with these meds. And once we get that, then therapy can be really effective. And that therapy that's most effective in this setting is cognitive behavioral therapy, which is you're going to actually change the way that they behave when they have a certain thought. And once we start to modify that, we're going to be able to change what their function looks like to other people. Not just what they're thinking about, but specifically what they're doing in a certain situation. So this requires, persistence and ongoing, ebb and flow of this disease for a while. It takes, like I said, 18 months to 2 years before the brain stabilizes that dopamine axis. And you shouldn't even start to try to think about weaning medications until that 18 months. In very rare cases is that helpful and not actually harmful. So absolutely an important aspect of that. So I want to talk about we'll give a case. And so this is a 23-year-old male with a history of taking 30 Percocet a day for the last year. He's missed 2 appointments. Yelled at the front desk staff a bunch of times, states that if he does not get his medication here, he's just going to go somewhere else. This is another day in my world, but this is a patient who can be very frustrated. And they show up and and they're demanding and frustrated. This is the disease. Again, you have to train your staff and not only yourself. You have to train the people at the front desk and the security staff and the medical assistant in understanding that this disease is about behavior. And so bad behavior is the rule when you start. So if they come in and they're escalating and they talk about it, I see that almost like somebody who has worsening chest pain in the front of my office. I bring them back immediately, and we deal with that. And it's not that we bring them back immediately and write them a script. It's usually quite the opposite. But so let's look at this. So the question would be, what is the most appropriate next step? Are you going to fire the patient, tell them to get another doctor? That actually happens most of the time. You're going to write in for 30 Percocet a day. I've also seen that. Do an addiction intake and give them the options for treatment, or just pick another job. I've actually had many people just pick another job, and there are days that I think that as well. But you could do a full addiction intake and give him the options for treatment without telling him that day he has addiction. We still have to do a full understanding of what's going on with this patient, which means what is going on in your life surrounding just the drug use, not just focusing on the drug use, because we know that's an issue. Do you have stable housing? Do you have capability of transportation? Are you involved in the criminal justice system? Are you in a safe place? What are what is your education level? What are you having to deal with on a daily basis? Are you living in a drug house? Do you maintain your income from selling drugs? I mean, these are all things that need to be talked about with the patient, just like you're taking a diabetic history. And this, I find, is the most stabilizing pathway for dealing with these patients, is to sit down and have just a frank, basic conversation. Look, I can't write you for 30 Percocet because nobody should be writing for 30 Percocet. That's silly. And they say, well, I'm not taking that. I'm only written for 6. And I go, yeah, but when I run a MAPS report, or PDMP, it shows that you're actually getting enough prescriptions to take 30 a day. So my assumption is you're taking 30 a day, because if you're not, you're selling them. I'm not here to judge. I'm just telling you that's what I have to look at. So here's our pathway. We need to get you onto a safer medication that does basically the same thing. The safer medication in this case would be most likely buprenorphine. So how do we do that? And then go through all of those things. Now, I've written the Michigan Medication-Assisted Treatment Guidelines for opioid use disorder, and it talks about a lot of these transitions, and we're about to put out version 2. So that'll have also all the drug testing pathways, criminal justice interaction. It has a pregnancy chapter to deal with that from those aspects. And also it talks very specifically about transitioning from one to the other and dosing requirements, things of that nature. So this is, hopefully that'll be helpful. And it's written so that it can be used in both the specialty world as well as primary care. So that you at least have a pathway forward, and also something you can show your patient to say, look, this is what the guideline says. This is the evidence, and this is where we're going to go. And I find that that's also pretty easy to let them learn about that and give them either a copy or the web link for that. So if we look at all of these things, the major concepts that we need to talk about, really sit in the brain. And if we start to change the understanding of this disease and know that this is a chronic neurobiological disorder that has effective treatments, and if we talk about effectiveness and outcomes, so effectiveness for a publicly funded patient, again, not that patient with all of the disability, with short-term disability that pays their full salary and the ability to go back to work and a very strong family around him. Not that person. This is the person who is on Medicaid, and their family may have even caused a lot of this through early life trauma. So in this patient, we have to really begin to think about what is our best pathway of treatment for them. Sorry, I lost my train of thought. So let's see. It's nice that they're actually putting this down. So for my ramble, it comes off the page. Right, so effectiveness, sorry, I was on effectiveness. So effectiveness of outcomes. So the effectiveness of outcomes, so if you take our patient who's publicly funded and you put them just in a abstinence-based 12-step program, it is a 96 to 98% failure rate at 1 year. And the failure rate is a full relapse of all the behaviors associated with addiction as well as utilization. So So that's pretty bad. That's pretty abysmal. If you take a patient, you put them in independent, one-on-one directed cognitive behavioral therapy, and they show up. So this means that they actually are still retained in treatment and they show up. This can be up to 23 to 24% effective. It's much better. It's still 76 and 78% not effective. So we need to keep that in mind, is that it's mostly not effective. If we do just buprenorphine, it's also about 22 to 25% effective. So if you just write a script and you do nothing else. But again, it's almost 80% ineffective by itself. If you add the behavioral therapy, the cognitive behavioral therapy, along with the buprenorphine or methadone, and we haven't finalized all the studies yet for the naltrexone, but if you add those two dopamine stabilizing medications, one or two of those, never two at the same time, but one of those meds and the therapy, you're going to get up to 65 to 70% effective rates. That's as good as any other disease we treat. But for some reason, we have some weird emotional connection with the treatment of this disease. And we start to, connect emotionally to writing medications or using medication-assisted treatment. And that doesn't really make any sense since the evidence is very clear. If you write a medication and you do therapy, we're 65% effective. If you put them in the old-style pathway, you are 98% not effective. I mean, that seems to me to be pretty easy math to think about. The state is working vigorously to take away the one-year limit on the Suboxone or buprenorphine so that can be written as needed longer term, but they have to do this in such a way that we as clinicians or those of us that deliver care through a system of care put in appropriate policies and procedures so that we don't just turn opioid treatment facilities or substance use disorder treatment facilities into other pill mills. We don't want to replace oxy with buprenorphine on the streets, and we don't want that diversion. And you're lying to yourself if you say it's not diverted. It is. So we have to put in good diversion control pathways for this. And the good, diversion control pathways very specifically, are using the lowest dose that does the job, seeing a patient more often. We see our patients once a week for 6 weeks, and then once every 2 weeks for 8 weeks. If they've had clean urine and their function is stabilizing and they're following through with all their other obligations with therapy, then we'll move out to a month. If they don't, or they're having a relapse of those behaviors, then we actually go from every 2 weeks back to weekly. And we do that until we get them stable, and so sometimes we'll ebb and flow early. But seeing a patient on a Monday, writing them for 30 days, and they'll see in a month, that is not okay. That is not standard of care. It is extremely below standard of care. So we have to figure out how we build a better licensing and regulatory framework around this so that we can help people to know what are the safe ways to deliver this medication, to this population so that it's not diverted, so that we don't cause a problem when we're trying to fix a problem. Methadone, the methadone clinics, we need to take a methadone clinic, which is an extremely effective instrument in the treatment of IV drug abuse for decreasing risk, and you immediately decrease the risk of HIV, hepatitis C, endocarditis, accidental overdose, risk of going back to jail. All of those things are immediately decreased by putting on a methadone clinic. But it's just odd to me that we have board-certified addiction doctors who treat one piece of one disease with one drug and have an entire clinic dedicated to that. It's so isolating. And so my hope is that we move forward in thinking about, we have all this infrastructure and all this brick and mortar. Why aren't we turning those into modified medical homes where the addictionologists stay there and we still deliver methadone treatment, but they also deliver naltrexone and buprenorphine and all the medications for alcohol use disorder and marijuana use disorder, and they can get primary care there for themselves and their family, so that they can get informed care for their family and where they understand the disease of addiction. These are things we have to start moving toward as a state and within payment models, and that because the medication-assisted treatment from evidence-based and a math standpoint is kind of a duh thing. I mean, it's the equivalent of, well, should we write insulin or not for diabetes? It's been answered to that level. So we have to remove the emotion out of it and start making decisions based on the data, science, and math so that we can improve the care of these patients on a very consistent way. All right. So with that, I want to leave some time for questions so we can dig in on any of those issues. So I'll hand it over to the operator to moderate those questions at this point.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Once again, if you have any questions at this time, please press the number 1 key. Our first question comes from Abby Corley with Priority Health. Please go ahead.
Yes, Dr. Waller, do you have a list of addictionologists or those that can prescribe like naltrexone and those kinds of things across Michigan?
So I just took over as the president of the Michigan Society of Addiction Medicine, and that is first on our list.
Okay.
I took over in June, and so we're trying to. It's been kind of a non-entity for a while, as far as statewide, and so we're trying to figure out how we really catalog those that are willing to see these patients. Now we have to be careful because the minute I put out a list, they're going to be like I am with a 5-month waiting list, and so we have to figure out how to, onboard treatment and create access in a smart way so that we don't really bury these offices, and also think about some incentives for doctors to onboard the use of things like naltrexone, which is such an easy thing to do within a practice once you start doing it, but it does require a little bit of business changes and to be able to deliver those medications appropriately, but also payment incentives. From a payer side can be really helpful in those settings to say, look, we'll give you bonus payment for taking on these patients as compared to your normal fee-for-service. Little things like that, little carrots like that can be really helpful. But in short, no, we don't have a perfect list yet.
Our next question comes from Michelle Lewis with Partners for Health. Please go ahead.
If you have an individual that's 60 years old, and I know you were saying, Dr. Waller, that over time it's a behavior thing. A lot of people, especially family members, people get frustrated when the loved ones, I guess, don't comply. I guess that's the word to use. So when you have someone that has been abusing alcohol for so long, does the same criteria for 101 cognitive behavior therapy and medication, will that help, or does it change with age, the different treatments?
Yeah, that's a great question. And so the short answer is it does not seem to. So for alcohol use disorder, once you get to that age, if you haven't had successful treatment, then you burned every bridge. And so the support systems, even if they want to be there, they're kind of just emotionally done. So medication still becomes really important early because they have to prove to the family that they're worth kind of coming back to the table and dealing with this. And the data currently shows that it's more of a genetic risk, or not really risk, it's a genetic decision whether or not the med's going to work. And actually, we're really close to being able to do, these pharmacogenetics to understand if somebody's a good patient for these different medications. We're not quite there, but we're very close. So the age doesn't seem to matter for the utilization of the medications. You just have to take into account if they're older, they may have more complicated medical issues that could be a contraindication for the medicine. But in general, the medicine still works the way it's intended.
Our next question comes from Charlotte Nellis with Spectrum Health. Please go ahead. Charlotte, your line is open.
I'm sorry, I didn't have any questions, and I didn't select anything.
Our next question comes from Catherine Blakely with Metro East. Please go ahead, Catherine.
Hi, I have a couple of questions. The first question is, could you elaborate on some other ways that you touched on natural ways to increase dopamine? Could you elaborate on some of those? And my second question is, the consumers that are taking methadone, and we actually have a coordination of care letter from physicians that are writing for their pain management, what suggestions or behavioral pathway treatment modalities would you suggest when there is a clear effort to work towards coordinating this care, but where do we move forward past just managing the pain? So would the client have a diagnosis of a pain management issue as well as a substance use disorder? that would be considered by your definition in remission with medication-assisted treatment, other than the fact that they have a pain management issue where they're still getting an opiate-based drug?
All right, so for your first question, the natural ways to boost dopamine, quite honestly, the longer I've done this and the more I've really dug in and looked at what we can do, the evidence shows that the group, like a therapeutic group setting, can be very helpful for that. So if you don't have your own group, like your family, you can do that. So this is why once a patient is stabilized with medication, that things like 12-step can be really helpful, because it's a group with like-minded pathways that are trying to get it better. The barriers that we run into for that natural aspect of dopamine increase is that, many people still within the 12-step world are still against, very black and white against medication, independent of what the data shows, that they won't just take the person where they are and they make it really difficult. So that's why we actually see a decrease in compliance if we send the patient to a general 12-step program. But there are ones that are very specifically developed. So that 12-step modality where you're rebuilding these bridges with family, you're coming to terms with a disease, and you're moving through it, those are actually things that will help rebuild dopamine. Mindfulness therapy is one of them that's been shown to do that as well, and it has actually a good amount of data for that. For the cognitive therapies and just giving somebody a roof over their head sometimes will be what you need to boost that dopamine with that last little piece. So it's just getting them moved up on the Maslow's hierarchy of needs. And so as you move up that hierarchy of needs, you start to really build that more robust dopamine response. But early on, the patients need a boost, and that boost is this medication. And until they can naturally, with these other interventions, increase their dopamine, they're kind of stuck, requiring that boost. As far as the pain and addiction, this is what I do for a few patients who have both a pain diagnosis and addiction. And opioid-based treatment for pain in a patient with an opioid use disorder is really tricky. And in fact, it really should not be directed by just a pain doctor. It needs to also be directed by an addiction physician as well. Because there are modalities that you can do. So I have patients who have like sickle cell disease, or patients with disseminated sarcoidosis, or patients with complex regional pain syndrome that may require opioids. And you have to split them into two pieces. Do they require them daily, or do they require them intermittently? If they require them daily, then you have to pick the safest way to give it. So things like extended release hydromorphones, which is dilaudid, but it's one pill for 24 hours, and it's crush resistant. And so they can't snort it or inject it, and it really doesn't have much street value. So using drugs like that, or transdermal buprenorphine, butrans patches, because it lasts for 7 days and very low diversion risk, those are things that you have to look at, so formulary decisions. If they need it intermittently, that just needs to be really closely monitored for those behaviors, which means that it needs to be followed up and not refilled without a follow-up to the addiction management pathway so that they can assess for those behaviors. But again, I go back to what I said, which is there is still no data to show that long-term use of opioids is beneficial. And it actually shows a decrease in function, a decrease in cognitive capability, a bunch of other side effects long-term, and then also this risk of diversion and overdose and all the issues we're seeing. But even for patients with chronic disease, and when I trained in Philadelphia, we had a large portion of patients with sickle cell disorder with necrotic bones and all this kind of horrible stuff. When we got them off of opioids, they actually did better. Because their body would ramp up their pain capabilities. And you also would be able to get them earlier in a crisis because you weren't masking some things. And so it decreased hospitalization to have them on lower doses. So I think it's a very slippery slope to use the drug of choice of an addicted patient as a drug that you use to treat another disorder, another problem. So interventional pain management is huge, figuring out if you can block a nerve or burn a nerve or any of those things can be really helpful. Physical therapy, mindfulness, cognitive behavioral therapy all have better outcome data than opioids for all of those things.
The next question comes from Chrissy Hanna with Spectrum Health. Please go ahead.
My question was actually answered. Thank you.
We have another question from Catherine Blakely with Metro East. Please go ahead.
What I'd like to know, I understand the mindfulness and the 12-step, the social piece. But even, my question, even encouraging exercise, which increases dopamine, do you do that or consider that as an option? That's one question. And the second question, what efforts are being made to educate the physicians moving forward in terms of really understanding addiction? And I'm actually talking about what happens in schools. Is there any effort to address the medical schools to increase the interest in studying addiction, as well as just educating them about what you've done today? I think would be quite beneficial to many of the people that we have to interact with on a daily basis to coordinate care.
Yeah, so for your first question, I don't know why I didn't mention exercise. That's the only way I stay sane. I run 4 or 5 days a week, and my weight fluctuates on stress, and actually the opposite, because I run a lot more when I'm stressed, and so now I'm at one of my lowest weights I've ever been. But my dopamine gets fully stabilized by going for a run, and it's great. But so exercise is great. We do try to onboard that early. It's a really tough sell culturally for a lot of our patients, and we still push it, and we get them into PT for an assessment, and we try to give them structural ways to actually exercise instead of the general term, you should go exercise. We tell them exactly what to do. But most of them can't afford gym memberships and things like that. So it's either you go out and go for a walk, or here's some basic things at home for cardiovascular. But absolutely that. There's actually a good subset of research on exercise for dopamine stabilization. The other piece for education, if you look on the slide on the bottom left corner, is complex.care. So this is a Robert Wood Johnson funded website that we're building right now. It has a landing page that you can go to that's going to have 265 lectures that are 5 to 10 minutes long, based purely to educate everybody from the patient to the specialist on pain, addiction, and behavioral health. And it's going to be fully integrated, and it'll build a curriculum based on whichever level you are within that. And we've talked to Michigan State at this point about onboarding this as a mandatory requirement for medical students in their 4th year to complete 20 hours of this online thing. And it's free. That's the beauty of it, is we're building all this content, and it's going to be available for free forever. So if you want, you can sign up for on the web page. You just put your name in and your email address, and when we finally put the content fully on the website, then you'll get a couple of emails to let you know. But they're not going to get anything, so it'll be silent for a while. But that's going to go live in December.
Once again, ladies and gentlemen, if you have any questions, please press the number 1 key. Our next question comes from Amy Park-Gadecki with CMH. Please go ahead.
Hi. I'm wondering if you have any special considerations or recommendations for working with individuals that may have cognitive deficits, and thinking specifically about individuals that have an FASD, fetal alcohol spectrum disorder, or other developmental disabilities.
Yeah, these are particularly easy, oddly enough, and so you would think that they would be more difficult, but the thing that they generally have as a rule by diagnostics is a more concrete thought process. So I didn't realize this until one of my 7th or 8th patients in my clinic that we started 4 years ago, he was Down syndrome, chronic pain with gout, with congestive heart failure, and an opioid use disorder. So I'm like, I have no idea what to do with this yet. And what I found is that if you're just very concrete and you lay down very specific parameters of why and why not, what happens is we try to use some of the cognitive behavioral therapy trickery that goes on, the change talk and the change. That doesn't help in those patients with cognitive dysfunction. It needs to be very concrete. So the remedy for the issue has to be just as concrete as the thought process that they have. And so that takes a little while to figure out with the patient, but generally the medications still do their job. They still stabilize, and actually they're more compliant with the medication than other subsets of the patient. And so I do find that you don't have to tweak it too much, except you really need to be much more concrete with therapy input as compared to the other subset of patients.
Dr. Waller, this is Mark Lausch at MPRO. I was wondering if you could do me a favor. We're going to have to end the presentation at this point. Could you do me a favor, under my name, right-click it and change me over to the presenter on your screen? Yeah. Because we have a couple slides we want to show out there. That would be great. Thank you so much. Thanks, Dr. Waller. That was an awesome presentation. And thanks to all of you who asked questions. I'd like to thank Macomb County Community Mental Health for their funding of this event through their Health Innovation Grant from the MDHHS, and to Dr. Cory Waller for his time and commitment to improving our understanding of substance use disorders. A recording will be available at youtube.com/LSQIN, and all attendees, please complete the evaluation that will come up on your screen, and a certificate of attendance will be mailed to you in 2 to 3 weeks. If you have any questions about the certificate, please contact me, Mark Lausch, at mlausch@mpro.org. You must complete the evaluation in order to receive the certificate of attendance. Dr. Waller, thank you so much for your time and your presentation.
Yeah, no problem. And it's perfectly fine to, that's all a question we talked about. It's perfectly fine to disseminate the slides.
Oh, that's great. I was just going to ask you that. Thank you so much.
Yeah, no problem.
Okay, and it looks like the evaluation questions are coming up on right now. So if you could take the time to fill those out, we greatly appreciate that.
Great. Thanks, everybody. I want to go. Have a great day.
Thanks.
Yep.
Thank you, ladies and gentlemen. This concludes your conference call. You may disconnect at this time.